Thank you, Gordon. I think I feel the need to hold hands while we're talking. That'll surprise my colleagues in surgery. My name is Jeff Sedlak, and I'm the Medical Director for Maine for Harvard Program, as Gordon said. I'm also a proud Maine Medical Association member and a general surgeon most recently in Belfast. One of the great joys of my job at Harvard Pilgrim is being asked to meet and to introduce some really exceptional people. And this meeting today is graced with a star. Dr. David Blumenthal comes to us today from Boston, where he's the president of the Commonwealth Fund. That fund's mission is to promote a high-performing healthcare system that achieves better access, improved quality, and greater efficiency, particularly for the society's most vulnerable and the elderly. Prior to this very important work, Dr. Blumenthal had been a practicing physician at Brigham and Women's Hospital, a professor at Harvard Medical School, the Harvard School of Public Health, and the Kennedy School of Government. He's perhaps best known for his role as presidential advisor to President Obama as the National Health Information Technology Coordinator. Dr. Blumenthal was instrumental in developing the Meaningful Use Guidelines. If that was not enough, Dr. Blumenthal is also an author, having written one of the most interesting books it's ever been my pleasure to read, The Heart of Power, Health and Politics in the Oval Office. I was fascinated to learn, Dr. Blumenthal, that the formative part of Richard Nixon's approach to health reform was the deaths of 2 young brothers of tuberculosis. Dr. Blumenthal is speaking today to give us a 30,000-foot view of health policy, information technology, and perhaps some insights into the intersection of politics and healthcare. Please join me in welcoming Dr. Blumenthal.
Can you all hear me? Am I being amplified here? I often find that since I'm height challenged, some of these microphones don't quite get high enough. But fortunately, Dr. Sedlak is a tall gentleman as well, so paved the way for me. Anyway, it's a pleasure to be here. I feel like I'm coming home. Why a picture? There are enough of you in this audience who are of a certain age that you may remember this product. And I spent a fair number of years, more years ago than I care to remember, working as a camp counselor near Waterville, Maine. And when we would get our nights and days off, we often patronized some of the establishments in Waterville, Maine. And there were a lot of people who worked in the factory making legions in those days. And so I wore them myself, of course. We all did. I don't think they're made anymore anywhere. But Maine does have a resonance for me, and some very, very fond memories as a wonderful place to spend the summer. The winter, not so sure, but the summers were really wonderful. So I'm going to talk about our healthcare system. I'm a primary care physician. I'm used to doing annual checkups. And what I'm going to do today is take Uncle Sam's healthcare system through a checkup. And it's, I don't know how often Uncle Sam gets checked up on this score, but every once in a while makes some sense. And when you think about checkups for patients and normal human beings, you think about blood pressure and heart rate, respiratory rate, temperature, vital signs. The vital signs for our healthcare system are a little different. They consist of, by some measures, quality of care that's available to our population, cost of care, access to services, and equity of services. And those are the dimensions that I'm going to talk about. And the first one I'm going to talk about is quality. And I'm going to talk in general about the positives and the not so good, and maybe the slightly ugly stuff. But the one thing that I do want to say as context is that there is a lot of positive things to say about our healthcare system right now. You wouldn't know it listening to some of the discussions that we have, And maybe you need to be as old as I am to have that historical perspective on whether things are positive or negative. But I do have a bunch of positive things to say, and I hope you'll bear with me. So, let's talk about the quality dimension. Maybe that's the equivalent of blood pressure. You need a baseline to think about where we are right now with quality of care. And this baseline is a study, a really momentous study that was published in 2003 by my friend and colleague, a team led by my friend and colleague from RAND Corporation named Elizabeth McGlynn. She actually now works at Kaiser Permanente running their major research center. And what Beth's work showed was that at that point, and we're talking about the late 1990s, by the time this was published, it was about 4 or 5 years later. On average, an American seeing a physician could expect to get the right care about half the time. Actually, 54.9% of the time. Applying RAND's guidelines to record reviews of 6,700 patients in 12 American cities. So that's the baseline. What's happened since? Well, there's actually been improvement. It's a complicated slide, but if you look at the far, I guess from yours, the far right-hand side, and look at that bar chart, it shows that in the last, from the period 2001 to 2013, the annual rate of improvement in those quality, in overall 191 quality measures, the annual rate of improvement in 191 quality measures exceeded 1% for about 58% of those, so a majority. So we have been seeing progress in quality measures over time more commonly than we've been seeing lack of progress. And in certain dimensions, like patient-centered care, patient safety, healthy living, effective treatment, we've actually been seeing 1% or more annual rate of improvement in those measures for considerably more than 50% of the metrics being followed. So that's not bad news. You wouldn't know it just by going to work every day if you're a physician or a nurse or a healthcare policymaker. We don't talk about where we're making progress very much, but we are making progress in quality. If you have diabetes, you're a lot better off now than you were 15 or 20 years ago. It's not great to have diabetes, obviously, but in the United States, if you have diabetes, your chance of having a heart attack, a stroke, an amputation, end-stage renal or chronic kidney disease has gone down pretty dramatically over the last 15 to 20 years. That's undoubtedly partly the result of better care. It's also partly the result of better of changed behaviors on the part of people with diabetes, better compliance with care, but it's definitely an improvement in the baseline that we were living with in the 1990s. As a clinician who practiced for years in a hospital, in primary care, but I also attended on the medical service, this particular data to me has real significance. So, hospital-acquired conditions have fairly dramatically been fairly dramatically reduced over the last 4 to 5 years. By that I mean urinary tract infections after catheterization, post-operative wound infections, venous thromboembolus or thrombophlebitis after surgical procedures, adverse drug events, central line associated bloodstream infections reduced 72% in U.S. hospitals in the 4 years between 2010 and 2014. When I was a resident, Central line infections were a fact of life. They just happened. There was nothing you could do about it. Too bad that patient needed a central line, but if they needed a central line, they had to live with the chance of infection. We now know that's not true. And it's not true for a lot of the errors that occur in adverse events that occur in hospitals. And we've now been proving that with unprecedented progress, a total of 70% reduction. What does that translate into in terms of human lives? Department of Health and Human Services estimates that we've saved 80,000 lives as a result of this reduction in hospital-acquired conditions over that 4-year period from 2010 to 2014. The largest chunk of those lives, 42,000 in the dark blue, is associated with pressure ulcers. Those of you who are nurses understand the toll that pressure ulcers take. As a physician, I can tell you that we're not often terribly involved in pressure ulcers. It's the nurses who live with and deal with them. That's a very big change in the rate of occurrence of those particular problems and the life-saving effects of better care that we've accomplished. Now, I have to say a word about electronic health records. This is not a direct quality effect, but I remain convinced, maybe just an article of faith, but I remain convinced that electronic health records are going to yield dividends in terms of quality. Actually, there's exceedingly good data from randomized controlled trials that computerized decision support and computerized provider order entry do reduce adverse drug events and do create improvements in quality. So when we get records to the point that we have added in those decision support capabilities, we will see major value realized in terms of quality. But one thing that has happened is that virtually now the entire healthcare world, ambulatory physician practices and hospitals use electronic health records. That's a big irritation to some physicians and probably to some nurses as well. We can perhaps in question and answers talk about the balance of benefits and costs associated with electronic health records. But that's a really remarkable change. We've gone from the paper world to the electronic world. The information revolution has finally arrived in medicine. Now, not so good news. I was chatting with a member of the audience about the opioid epidemic in rural America and in Maine. And that epidemic partly explains this phenomenon, which is that mortality rates in the working age white adults in the United States are no longer declining at the rate that is expected. There have been some increases in mortality rates associated with drug abuse, suicide, and liver failure. But there's also been a generalized failure for mortality rates to decline at the expected rates. They've been declining, as this graphic shows you, for decades. That decline has stopped. It's not, by the way, all due to drug abuse, suicide, and liver failure. It's due to a bunch of other conditions as well. I don't know why this is happening. Why is it that we are the only country in the developed world that has increases in maternal mortality? That is a simply astonishing thing in a modern society. But here we are. From 7.2, a rate of 7.2 per 100,000 live births, to more than double that amount now. As I said, don't know what it is, but it's certainly part of the quality picture and the not so good news that we are dealing with in our country. And again, obesity among adults. With children, obesity rates, the increases in obesity rates have leveled off in the last few years, but they continue to move upward among adults. And that, it's nice that diabetes complications are less common than they used to be, but the rate of diabetes will continue, the incidence of diabetes will continue to grow as long as obesity remains as prevalent as it is. So let's talk about the next vital sign, vital dimension of a checkup, access to care. Again, some good news and some bad news. Now, if you had asked me when I was a medical student, or then a resident, or when I worked for Senator Edward Kennedy, or when I worked at the Kennedy School over the course of my career, whether in my lifetime I would see this kind of a graphic with respect to the rates of uninsurance in the United States, I'm not sure that I would have ever thought this would happen. But here we are. It's around us. It's something that many of us have worked years for, and it's happening. A 20 million reduction in the numbers of people in this country who lack health insurance. Time to the implementation of the Affordable Care Act. We'll talk more about the Affordable Care Act later. That is an incontestable, dramatic improvement in the general status of our healthcare system. And again, not talked about, but a very important fact. If you ask people in surveys the likelihood or the frequency with which they report that they have failed to get care because they can't afford it, you will see, associated with the implementation of the Affordable Care Act and with the spread of insurance, a reduction in that rate of reporting. So among 19 to 64-year-olds, non-elderly Americans, the percent reporting that they didn't get needed care because of cost in the last 12 months went from 43% in 2012 to 36% in 2014. A lot of that is the result of reduced expenditure on, or reduced exposure to expenditure despite the increased cost of drugs, to reductions in exposure to drug expenses, reductions in exposure to annual physical exams, coverage of preventive services, and reductions in hospital costs associated with insurance. Now, the other side of the coin is always a good side and a bad side, and this is something that we've heard a lot about in the last few days as a result of the discussion about Affordable Care Act premiums. If you look at the far left-hand side set of bars, what you'll see is from 2003 to 2014, the proportion of Americans, privately insured Americans from 1964 in age, who don't have a deductible. Went from 40% down to 25%. And if you go all the way over to your right and look at the proportion of Americans who have a deductible of $3,000 or more, it's gone from 1% over that time period to 11%. More and more Americans have insurance, and this is not just an Affordable Care Act phenomenon. It's about the employed population. 156 million, 177 million Americans who get insurance in the workplace. They are experiencing a huge cost shift that wasn't there 20 years ago. That is a big new factor in the American healthcare scene. Cost of care. Obviously, deductibles expose people to cost of care. And here there's also a positive story and a not so positive story. You have to start when you're talking about the cost of care with the big picture. So this slide may be a little surprising to you. It's not talking directly about healthcare costs. It's talking about GDP among major industrialized countries in 2014. So if you start at the upper left-hand side, you'll see that the US of A, as we have come to expect, has the largest gross domestic product in the world, $17+ trillion. Right under us is China. They were about to overtake us in a very short time, but their rate of growth has slowed somewhat, so maybe a little bit longer before they overtake us. And then there's Japan at 4.8 trillion. Then there's Germany at 3.8 trillion. And then you go up to the next column, and then there's, wait, what is that? That's the United States with a stethoscope. That is the U.S. healthcare system. The U.S. healthcare system, if it were a country, would have the 5th largest GDP in the world. If you floated the American healthcare system off the coast here of Maine and made it an island unto itself, it would have a larger gross domestic product than France, or the UK, or Canada, or Australia, or New Zealand. That's pretty impressive. Aren't we lucky to work in a country that's so wealthy? That shows you the size of the problem we are trying to tackle, and also the baseline from which we are starting, whatever journey of improvement we are undertaking. We are trying to change an economy larger than France when we talk about cost management. That doesn't happen overnight. No matter what you conceive of, no matter how good you are as a policymaker, you just don't turn that kind of a ship around on a dime. Nevertheless, there's a positive story here. You're talking about annual rates of increase, not total expenditure, but annual rates of increase. We are having a pretty good run right now. Some of you may have seen, if you were looking at CNN yesterday morning as I was, you may have seen the Secretary of Health and Human Services, Sylvia Burwell, trying to make this case in the face of the 25% figure that has been discussed so prominently about the Obamacare premiums. She was trying to make the point that we are at a historically low level of annual rate of increase in healthcare costs for the country as a whole. Now, the country as a whole is a very, very vague idea. But nevertheless, it is absolutely true that we are in a period of relatively low inflation in healthcare costs. We've been waiting, those of us who follow this, we've been waiting every year for this cost problem to explode again, because it's certainly been my personal experience that every period of reduced inflation is followed by a dramatic surge in inflation. For example, look at 1995, 4.2%, and then 2001, 2002, 8.6%. That's the typical roller coaster picture. We haven't quite seen that yet. We've been at a relatively low rate of inflation for well over a decade. Now, drugs. Before I go into drugs, let me talk about Medicare, because this is a very interesting story. So look at, this is a chart of annual rate of increases in Medicare spending. You may or may not be aware that we are, again, at historically low rates of annual increase in Medicare spending per beneficiary. I'm a Medicare beneficiary. The amount of spending that's being committed by the federal government for me is actually, for the last couple of years, has barely been going up. And I'm talking personally, I don't actually use Medicare because I have private insurance still, but for Medicare beneficiaries like my mother-in-law, that number has been pretty stable. It actually was down to 0 in real terms in the 2012-2013 period. That's a pretty good deal. Absolutely low, very low year-on-year expenditure increases for the many, many older and disabled Americans who are Medicare eligible, and for the U.S. federal taxpayers. Now, drugs. We hear a lot about drugs, and drug price increases are a big problem. Absolutely no question about that. We've seen a surge in drug prices and drug spending in the last couple of years that has captured people's attention. It hasn't hurt to have had a few public hangings of drug pharmaceutical executives, just to make drive home the point. I'm speaking euphemistically here. But there may be some people who wish I weren't just speaking euphemistically. But what's interesting about drug expenditures, as this graphic shows, if you look over to the right-hand side, is that the inflation we've seen in the last 2 years is historically typical. What's atypical was the very low rate of increases in drug prices and drug spending from the 2007 to 2013 period. That's what was atypical. We had learned to live with 10%, 12%, 13% increases in drug expenditure year on year for decades. And then suddenly, the floor fell out under drug costs, and we had this period of remarkable relief of annual increases in drug spending. Now we have resumed an historic rate of increase, higher than it should be, certainly higher than it should be by international standards, but not atypical. Putting all this together, and again, stepping back to the big picture, what this slide does is looks at the difference in projected spending from 2014 to 2019, a 5-year period, on aggregate national health expenditures based on the pre-Affordable Care Act projections of what we'd be spending as of 2010, and what our current forecast is based on our experience with healthcare costs recently. And our experience has been a lower rate of increase in healthcare costs than historically has been common or than was predicted. We are on a path to save $2.5 trillion compared to what we expected to spend 4 years ago. $2.5 trillion. You wouldn't know it, just walking on the streets, just listening to the dialogue, you wouldn't know that. But $2.5 trillion that we expected to spend, that if the current rates of inflation persist, we will not spend. All right, let's move on. We've done quality, we've done access, we've done cost. Let's talk about equity. With the spread of insurance, we've had very dramatic reductions in the rate of uninsurance among racial and ethnic minorities and among low-income Americans. So Hispanic, non-Hispanic blacks, non-Hispanic Asians, non-Hispanic whites, but especially Hispanics and non-Hispanic blacks have experienced very dramatic falls in the rates of uninsurance, mostly since 2010, 2012. On the other side, with respect to equity and disparities, we are not seeing dramatic narrowing of quality gaps. There's some narrowing of quality gaps, but not what we might expect if we were really making progress in narrowing the quality differences between people of different race, ethnicity, and income. So this is an Agency for Health Research and Quality data on the percentage of quality measures for which measures were improving. That's the pink part of the bar, for which there was no change. That's the green part of the bar, and for which there's worsening. And if let's just look at black versus white, the middle bar, for example, you'll see that 46% no change, 46% improving, 8% getting worse. So we're getting better on about half, but on the other half or more, not a lot of progress. So we're not making progress on the majority of measures. Now the mortality gap between blacks and whites is reduced. If you look at 2013 compared to 1968, the difference between those two graphs is narrowed. That's partly because black Americans have improved in terms of mortality rates, but it's also because the rate of reduction, as I noted before, for white Americans has slowed. probably not the way you want to narrow the gap. But it is encouraging that among African Americans, that rate of increase has sustained itself, even during this period when among white Americans, especially working age white Americans, the rate of decrease has not continued. Trying to find the right angle here. There we go. All right, let's shift from a checkup to continue the analogy, to just talk about a very powerful dose of new medicine that was administered to Uncle Sam's healthcare system in 2010 with the passage of the Affordable Care Act, and then especially in 2014 when some of the coverage provisions of the Affordable Care Act went fully into effect, especially the opening of the marketplaces and the availability of expansion of the Medicaid program. So, Medicaid. You guys have had a very vigorous debate here in Maine about Medicaid. I can tell you about that. 31 states and the District of Columbia have expanded Medicaid. 19 states have not expanded Medicaid. You are among those states. This, of course, was a disappointment for the crafters of the Affordable Care Act. Maybe not at all a disappointment for those who opposed it. But there is, of course, a picture here of the Southeast, the South, and the Midwest. Maine is something of an exception geographically to this pattern, and I'm not going to comment on what that means. But nevertheless, it is a disappointment in terms of the implementation of the Affordable Care Act. If Maine had expanded Medicaid, and if it does expand Medicaid in the future, it will realize important benefits. So this is a study, these are some results of the study that the Commonwealth Fund funded, done by a group at Harvard led by Ben Summers. And it uses surveys to look at the effect or the experiences of people who were Medicaid eligible in 3 states, Kentucky, Arkansas, both of which expanded Medicaid. Arkansas expanding it through a waiver that allowed Medicaid eligible individuals to buy private insurance, and Kentucky expanding traditional Medicaid, just the old Medicaid, the vanilla Medicaid program, compared to Texas, which did not expand Medicaid. So the baseline here is Texas. The differences are the pluses and minuses are with respect to Texas as the comparison. And what you see is that people report that 12% more of them, compared to Texas, in Arkansas and Kentucky, have a personal physician, had a checkup in the past year, received regular care for a chronic condition, and 5% more reported that they were in good or excellent health, or excellent health, excuse me. By the way, self-report of health status, excellent, good, fair, poor, is a very powerful predictor of mortality, confirmed time and time again in public health studies. If you want to predict the rate of death in the population, find out the proportion of those people who report their health status to be fair or poor. So this is not just somebody waking up one day and saying, I'm having a good day, or I'm not having a good day. This is very important public health data. In Kentucky and Arkansas compared to Texas, cost-related delays in care were 18% lower, and 14% fewer people had trouble paying medical bills. So this would be the picture you could expect if you expanded Medicaid in the state of Maine. There we go. The uninsured rates in the United States, rates of uninsured rates in the post-Affordable Care Act era are very, very closely related to Medicaid expansion. So this looks at the map of the United States in terms of quartiles of remaining uninsured Americans in those states. Top quartile being the very light blue, the bottom quartile, highest rates of uninsurance being the dark blue. You can see some overlap with Medicaid expansion here. Actually, you all are in the second quartile. You must have pretty good coverage for your privately insured, non-Medicaid eligible population because you're not in the same boat, for example, as some of the other non-expansion states like Texas or Florida or Georgia or South Carolina or Louisiana. Now we're in some difficult times for the Affordable Care Act. This slide was done a while ago, so it wasn't changed this week when we heard about the 25% average increase in premiums in marketplaces in 2017. That affects about 1.7 million Americans. It's just 1.7 million Americans, but it's certainly gotten a lot of attention, and it's not welcome news. We, of course, had fewer enrollees than anticipated in the Affordable Care Act. About 11 million compared to the 20-something million in the marketplaces. This is just about the marketplaces. So fewer enrollees in the marketplaces than we anticipated. A substantial part of that reduced enrollment is related to the fact that employers have stayed with supplying employer-sponsored insurance. There was a lot of speculation, and the Congressional Budget Office projected that quite a number of employers would say, been doing this, costing me a lot of money, I'm going to stop doing it and let my employees buy insurance in the marketplaces, and if their income is low enough, they'll be able to get federal subsidy. That hasn't happened. Now, those of us who live in Massachusetts could have told you it wouldn't happen because it didn't happen in Massachusetts. But we needed to do this national experiment to demonstrate that employers still want to provide insurance to their employees even when those employees could go into the private market and buy insurance as individuals. Two programs that were meant to stabilize the marketplace have, and especially the insurers in the marketplace, have gone out of business, have ended. One is a risk corridor program, another is a reinsurance program. These are both intended to buffer insurance companies against bad risks, unexpectedly bad risks. And they're sunsetting. Thank you. Their sunsetting this year is an important part of the 25% increase. So that was very clear. And there is, of course, concern about narrow networks and high deductibles that are both written into many of the plans that are offered on the exchange. Another issue that has arisen and been the subject of a lot of discussion is the reduction in the number of insurance carriers that are participating in selling insurance on the marketplaces. And this looks at the percent of counties. So keep in mind that the Affordable Care Act marketplaces are all about markets, and every market is different, and there are hundreds of them in the United States. And this slide looks at the proportion of counties where 1, 2, 3, or 4 or more insurers are available in the marketplace. And if you look over at the far left-hand side, from your perspective, you'll see that between 2014 and 2017, the proportion of counties with one insurer only went from about 20% to 26%. It dropped to about 7% in 2016, but then it bounced up again. Now, 74% of markets still have 2 or more insurers. So it's not that most Americans don't have competing plans on offer, but there is a quarter of counties. They tend disproportionately to be rural and poor because they're not attractive places to sell insurance. But nevertheless, 26% of counties lack true competition, and that's another reason why insurance rates have been going up. Now, is the sky falling for the Affordable Care Act? There are some some positives still that persist. And, you have to look closely at the coverage of the 25% number to ferret this out. But the fact is that among those who buy insurance in the private market, individual markets through the marketplaces that were created by the Affordable Care Act, 80% have subsidies that basically protect them against those increases. 20% don't, and they will feel those effects, but 80% do. If you look at the out-of-pocket costs for low-income people who are getting insurance in the marketplaces, they are pretty equivalent to what employer-sponsored insurance consumers are facing. So this law, for those who get subsidies or low income or lower than 400% of poverty in terms of their income for a family, they are getting pretty much the equivalent of employer-sponsored insurance. You don't hear that in the discussions. That's 80% of people getting insurance on the marketplaces. Almost 12 million, so 80% of those 12 million, 9.5 million Americans, through the marketplaces have the equivalent of employer-sponsored insurance. There are some insurers that are making money. A lot of them, interestingly, are managed care plans that used to provide, still do insure Medicaid patients. And one of the reasons that they are making money is that they have networks of providers that they have negotiated low pricing. So they have low costs. We also have plenty of options to make the marketplaces a success. There are plenty of ways to improve enrollment. We're just not doing it. So one way to improve enrollment is to provide navigators or supportive help, personalized help to people who are shopping for insurance on the marketplaces. That's been a well-demonstrated boost, multiplier of the proportion of people who, when they go on the marketplaces, actually get to make a purchase. Another is marketing. Good old marketing. It turns out that buying insurance is not like buying a car. It's not a big positive in your life. It's not like buying a vacation. It's something you do because you think you have to do it, and it's a lot of money. We don't sell things in the United States without marketing them, but there are many states in the United States where marketing is not possible for the marketplaces because those states have decided that they do not support Obamacare. So there's no marketing going on, except through private groups that are privately funded from philanthropic and other sources. I could go through a bunch of other things that would make a difference, but the fact is we could increase enrollment. So the bottom line is the Affordable Care Act marketplaces are having problems. Euphemistically, I've said they're growing pains. Opponents of the law would say that they are that they're end of life. But they can be fixed if we want to make them a success. They can be fixed. It's not that the marketplaces are fatally flawed, it's that we are not doing the things that could work to make them work. Now let me just say, I heard that we're in an election. I'm not very attentive to the news, so I had to be, my wife told me. So what about the plans of the two contestants? So we actually, at the Commonwealth Fund, I think we're the only independent authority that have actually tried to model the proposals of Mr. Trump and Secretary Clinton. And we started by saying, we did this with the RAND Corporation, very reputable, high-quality academic group that uses really, really rigorous peer review of its work. So we asked them first to figure out what would happen if we just repeal the Affordable Care Act. which is the position of one of the candidates, it would increase the number of uninsured by almost 20 million, not surprisingly, because that's about the number that have gained insurance. It would increase average out-of-pocket costs for people buying insurance in the individual marketplace, both on and off the exchanges or the ACA exchanges, by $15 million, and it would increase the federal deficit by $33 billion. That's why opponents of the law talk about repeal and replace, not just repeal. Because that's not a very pretty picture. Now, let's look at Mr. Trump's proposed reforms, starting with the baseline. The baseline is that we have 251 million Americans under the Affordable Care Act who have insurance. What would happen if you repeal the Affordable Care Act? That's the next histogram over to the right, the next bar. You would increase the number of uninsured or reduce the number of insured by almost 20 million. So let's then add on a fairly undefined proposal that he has put forward to make insurance premiums tax deductible. How would that affect the number of insured Americans? Well, it would bump it up a little bit, about 4 million. So you'd only have, after repeal, an increment of 15.6 million Americans without insurance. Now, let's say you did something else he's proposed, which is to block grant Medicaid. Well, it turns out that you have to make some assumptions about what happens to Medicaid, but let's say you just kept Medicaid spending the same as it is now. You would lose about 25 million, you would lose another 10 million or so, and you'd be down to 25 million uninsured. And then selling across state lines has a marginal benefit of about 4 million. So anyway you kind of put these proposals together, they result in more uninsured Americans. Secretary Clinton has a series of proposed reforms as well. I'm not going to go through them in detail, the time is getting short, but if you look at the ACA baseline, 251.6 million, go to the next point over, adding cost-sharing tax credits. That's a way of buffering the rate of out-of-pocket payments that people are making for insurance. You get about an increase of about 10 million in terms of the number of uninsured Americans. That's why I was saying there are things we can do to change how the marketplaces work and how many people buy insurance. We just are not doing it. Now, there's one other thing I want to highlight for you, because this will be an issue regardless of who's elected, and that is the case of House versus Burwell. Secretary Burwell is Secretary of Health and Human Services. The House, of course, is the House of Representatives. The House of Representatives is suing the Secretary of Health and Human Services and the administration because they believe that some of the subsidies that the administration is providing to people who are getting private insurance and individual insurance in marketplaces are not constitutional because they are not being appropriated through the normal appropriations process. And this court case is making its way up through the appeals process as we speak. It will not be resolved. Probably won't go to the Supreme Court. It will not be resolved before the election. It probably won't be resolved until well into the next president's term. But if it were to go in favor of the House, it would have a major effect on the protections that are available to people with insurance under the Affordable Care Act against the cost of care. So this is a very consequential, non-political, non-electoral factor. It is political, I shouldn't say it's not political, but it's non-electoral factor. I guess the only thing that would make it non-electoral is if the House of Representatives became Democratic and the suit was withdrawn. But I don't attach a lot of likelihood to that. So I'm delighted to have had the chance to talk with you. I think we have about 10 minutes for questions. Delighted to take a few questions, and then wish you well with the rest of the meeting. Yes, sir.
Thank you very much for your talk today. One of the slides that showed repeal ACA and not replace. At the very bottom, I think it said that it was going to cost the federal government $33 billion.
Yeah.
Why does it add to the deficit if we're not spending the money for the ACA?
The ACA is a very, very complicated bill. The insurance expansion parts of it are only a small part of it. And there are lots of tax provisions. For example, the so-called Cadillac tax raises about $80 billion. There's a device tax on medical devices. There are restrictions on Medicare fees that are very important in terms of reducing federal expenditure on Medicare. If you repeal all those things, you lose more money than you save from the subsidies.
Thank you.
Yes, sir.
Yes. Part of the reason, as I understand it, that it was rejected was that well over a decade we were deeply in the government, and we finally brought it into black, which resulted in an increase in education payments of 3%. So the more we spend on Medicaid, the less we have to spend on education, which we still don't even come near our funding requirements for education. And instead, if you increase the expansion of Medicaid, it will increase the cost for the state of Maine by $500 million, less than has been predicted for many other states. It's still a substantial increase, but it's back into the red. The Hospital Association in Maine lists Medicaid patients as being their second largest source of loss. They still prefer the expansion because it replaces their largest source of loss, which is people with no insurance. But still taking on a large group of people, 77,000 people, I think it is, where they are still going to be losing money, just not as much money as they would lose if they had insurance. So the first part of my question, and the second part would be quicker, is this all true, what I just said? You hear things, and some things you hear are true, and some things you hear aren't true. But from my position, that those other numbers you said, I think, are very true. And that $3 trillion, as I view it, is 1 out of $3 is wasted on bad quality. And so if we improve quality one segment, which is standardly available in many, many demonstrations, if we improve by 1 sigma, we will save $800 trillion. And that $800 trillion can easily pay for all of this extra cost. We could expand and take care of everybody in the country, reduce deductibles. I don't think it should go to 0 because there is a possible effect of being involved in this clinical decision. So to me, the solution to universal health care is to fix this $1 trillion wasted on wrong diagnosis, wrong therapy, therapy done incorrectly. That's where the vast majority of effort should be done, and I don't see it being done. So, that's the question.
Well, there are practical and empirical aspects to your question and philosophical aspects to your question. There are 30 states that have expanded Medicaid. You're implying that they're pretty stupid, right?
No, I'm just saying that we've been told that many of them are going to have a very large, over the next 3 years.
As you know, because you're very well informed about this, the first 3 years of Medicaid expansion were completely paid for by the federal government, right? Completely paid for. Now it's going to 90% matching. So there was zero additional expenditure for Medicaid if you expanded Medicaid in 2014 until 2017. Zero. So I don't know where the $500 million figure came from, but no state expanded Medicaid in 2014 paid an extra cent for that expansion.
These are expansions.
So then 10% going forward. Now there is some discussion about whether states that are going to join late will get the benefit of that 100% introductory going forward, which is a possibility, and I suspect that if there was a majority that was positive toward the Affordable Care Act, that might be a feasible thing to look at. But let's put that aside for a minute. There are many, many, many economic benefits to Medicaid expansion that affect budgets that are not in the healthcare domain. The dollars that flow in, tens of billions of dollars in states like Florida and Texas, result in employment, result in employed nurses, doctors, janitors, dietary workers, physical therapists, occupational therapists. They pay taxes. The revenues from those taxes go into the state budget. They don't, however, go into the Medicaid part of the state budget. That amount of money is never considered in the kinds of calculations you just mentioned. But the fact is that states that don't expand Medicaid are paying for other states to expand Medicaid and reap those full benefits. The third point I'd like to make is that you guys are talking about an opioid epidemic. Who is paying for the treatment of those people? Many of them are low income. They don't have access to substance abuse care. They don't have access to behavioral health care. That Medicaid is an instrumental part of dealing with that public health crisis. So the last point I want to make is a general point about where you put cost control or system improvement in the chronology of reforming the healthcare system. And I think this is, to some degree, a value question. We've been trying to get that 30% waste out for a very long time. And believe me, as Uwe Reinhardt says, one person's waste is another person's income. There's a reason why it's been hard to get the waste out, because we have entrenched stakeholders in this healthcare economy that fight tooth and nail to prevent the kind of changes you're talking about. That fight will go on. It's going to go on for decades. If we wait for that fight to be resolved, millions of Americans will die and suffer from untreated but treatable illness for lack of access to care. There are good studies that show that when young children are on Medicaid as children, they earn more and have better jobs as adults. Our problem is that we calculate things in 1 to 3 year return on investment. By the way, that's a National Bureau of Economic Research study. Medicaid is a human capital investment. It's a human capital investment. And we have to decide whether it's a worthwhile investment. And the data seems to show that it is. That 5% of people who reported who were more likely to report excellent health, are people who are not going to end up in the hospital. So, I think there are lots of rational arguments about why you should wait. Jimmy Carter, by the way, and you mentioned, not you, but Dr. Selleck mentioned the book that I co-authored. Jimmy Carter and Ted Kennedy had a knockdown, drag-out fight on this question. Jimmy Carter, being the very rigorous thinker and with an engineering mentality, absolutely supported your point of view. He thought we should have cost control before we had access expansion. Not your point of view. Well, the point of view you espoused. Reduce waste, change the system. So that's why Carter put all his political capital when he was elected into the hospital cost control bill, which was defeated. Kennedy always believed you should try to do both at the same time. And in fact, he actually believed that if you expanded access, you would have more opportunity to control costs than if you didn't. And I'm not trying to go through the logic behind that in the -1 minute that I have. But I think there's a fair argument about that. Anyway, I respect your point of view. It's a widely held point of view. It makes logical sense. But when you actually look at its practicality, it has a huge human cost. Am I about to finish? I'm finished. Okay, thank you very much.